exciting topic. So the first presentation will be given by Dr. Lina Marashi, who is presenting the work on clinical characteristics and outcomes of patients with severe acute respiratory infection and who are receiving empiric therapy with oseltamivir. So Dr. Alina, so I'd like to give maybe 10 minutes for a presentation or so, and then we would like to see or hear comments and input to the fellows and the residents to help them moving their projects forward. Dr. Lina, تفضلي. Lina. Dr. Lina, can you hear me?
Yes, I can hear you. You can hear me?
Yes, go ahead.
Yes, okay. This is the best I can do.
لا خليها على السكرين هذيك أحسن.
السكرين ديك أفضل؟ أوكي كده؟
Yes, better.
أوكي طيب السلام عليكم. I'm Dr. Lina, ICU fellow. I will start with my presentation. It is the clinical characteristic and outcome of SARI patient and oseltamivir comparing with those who are not. Okay. Okay. So background, we started acute respiratory infection caused by viruses are among the leading cause of morbidity and mortality. So patients with severe respiratory viral illness requiring ICU can present typically with hypoxemic respiratory failure. And ICU admission rate for influenza positive SARI cases range from 6 to 56% and fatal cases. So oral oseltamivir is the most widely available agent. An individual participant data of meta-analysis shows that those with influenza A viruses infection treated with the neuroamidase inhibitor almost exclusively oseltamivir was associated with reduction in mortality compared with those who are not. So the objective of this study was to describe the association of empirical treatment of oseltamivir in SARI patient compared to none, and to see if there is a mortality benefit and reduction in this group or not. So the design of the study, the setting is the intensive care unit, King Abdulaziz Medical City. It is a retrospective cohort study from SARI database. So we'll start with the baseline characteristic of the patient with SARI. So we have the oseltamivir group is 300 and one with the no oseltamivir group is 155. And the second table, we can see that the baseline characteristic of those patients, the SARI, the oseltamivir group were more symptomatic than the non-oseltamivir group, with statistically significant in the lower respiratory dyspnea, cough, and wheezing, and also fever. Continuing with this, we can see that also that more sick patient we can see in the non-SARI, in the non-oseltamivir group, but the SOFA score is not statistically significant, so they are not more. So in the oseltamivir group, we can see that the respiratory rate, oxygen, and BF ratio is lower than those who are in non-oseltamivir group, with statistically and shows that statistically significant. So they are more sick than the non-oseltamivir group. So out of the 300 oseltamivir group, only 244 tested for the influenza and for viral serology, and it seems that only 75 were positive for influenza A, H1N1. And here the lab, the chemistry comparing the oseltamivir group with the non-oseltamivir group, no much difference in these two groups in the term of chemistry. For the non-invasive ventilation, neuromuscular blocker, and any oxygen rescue therapy, we can see there is a statistical significance toward the oseltamivir group that they need more than the non-oseltamivir group. And hospital length of stay was more in the non-oseltamivir group when was statistically significant. So we have the multivariable logistic regression to determine whether the oseltamivir is independent predictor of mortality or not. We can see that the oseltamivir group was statistically significant with the reduction of mortality compared to those who are not. So interpretation of the data, patients oseltamivir were sicker than those who are not in the term of respiratory symptom, hypoxemia, need for rescue therapy, neuromuscular blocker. Out of those, only 244 were screened for viral etiology and 75 out of 244 were positive for H1N1 and influenza A. So as a conclusion, most of the patients who were having more symptoms, they were treated empirically with oseltamivir even before testing them for viral etiology. And it shows that there was a statistically significant reduction in mortality for the oseltamivir group.
Okay, thank you, Dr. Alina.
Okay.
Questions
Yes.
and comments? So a few things, this is an excellent presentation. I think a few things will help when you are writing this paper. I think the introduction needs to be a little more clear.
Yeah, definitely.
So the issue, what you are testing here, when we get patients with pneumonia to the ICU, some of us may start patient on oseltamivir, and sometimes we don't, right?
Yes.
That's what the study showed, right?
Yeah, yeah.
So
definitely.
Sometimes we start oseltamivir without any empirically, and sometimes we don't. It looks like we started typically when the patient is sicker, right?
Yes, yes.
Is that correct? Can go back to the. So
yeah,
somebody
definitely.
mild disease, people maybe they don't start oseltamivir. Maybe they will test more, that go up more. I'm just trying to make the reasonable interpretation of this that go up.
Okay.
This is a multi-center cohort study that we collected over like maybe 2 years or 3 years. So, so patient, yeah, so you could see saturation lower, PO2 is lower,
Yes.
PF ratio is lower. How about intubation? Are they more intubated?
There was no statistically significant intubation, but the non-invasive ventilation rescue therapy, yes.
No, this is later on admission. Can you go up to the first slide?
Okay, I will. This one?
So the symptoms. Stop here, stop here. So altered. Invasive ventilation is the same, but non-invasive more common.
Yes.
Rescue therapy. So they are different. So the question is, this is a big question that has no answer so far. Whether we should be starting oseltamivir empirically or wait until test is done, and if the patient is positive or not.
Yes.
And I think you are referring to a systematic review. There are very, very few studies in hospitalized patients. I think the systematic review mainly observational data, right?
Yeah.
So you have to say the systematic review of observational data. There are no randomized controlled trials yet.
Yeah, till now, yes.
Right. And in critically ill patients, are there any data?
Critically ill patient, I think they were comparing, yes, it was improving the symptom, the respiratory symptom, but sub-analysis, they chose no mortality benefit when they compared the two groups. But it was associated with improving the symptom. In one study, I read it.
Yeah. Oseltamivir is being tested mainly in outpatients. Randomized controlled trial, and that's why it's improvement in symptoms.
Yes.
This stuff.
Yes.
In hospitalized patients, there are very, very few studies.
Yes.
So when you are writing your paper, you have to make a case for people why you are doing the study. If many people have done it before, it has no value. So
yeah, definitely.
But if it's not done before, you need to show
critically
Yeah, that is done in outpatient. There are few studies in hospitalized patients.
Yeah.
Are there any? This is unique because this is critical patients only. But are there? We need to do literature review about the critical ill patients. That would be my suggestion.
Yes.
Comments from the group here of any suggestion to Dr. Lina? This will be an important paper, yeah, but we need to, I think, need to make strong arguments to support the conclusion. The other thing, do we have the timing of oseltamivir from ICU admission?
The timing, no, we don't have. We don't have. In this, no.
I think that would be important.
Yeah, agree with you.
If this information available, we should try to get.
Yeah, definitely.
Excellent.
Thank you.
Thank you very much, Dr. Lina.
Thank you.
We'll move to the next presentation, and that's by Dr. Model Yahya, who is presenting on hematologic malignancy, patients with hematologic malignancy who are admitted to the ICU after cardiac arrest. Dr. Modi?
Yes, assalamu
alaikum. Can you share?
Just sharing. Yes.
Yep. We want questions and suggestions from the attendees, because I mean, this idea to give feedback to the residents about their projects.
It is up here on the screen.
Yes. Yes.
The presentation move. Okay. Okay. Assalamu alaikum. My name is Modi. Good day, everyone. I'm ICU resident in National Guard Hospital. Today, my research topic is talking about outcome of hematological malignancies patients admitted to the ICU after cardiac arrest in KMC. Hematological malignancies vary in incidence, etiology, prognosis. Survival rate can result in significant morbidity and mortality, eventually leading to cardiac arrest with poor in-hospital outcome. So there is a study published in France from 2002-2012. It was a retrospective chart review in 7 medical ICUs, involved 133, found 24 patients were discharged alive from the hospital, with overall 6-month survival rate was 14%. Cancer incidence in Saudi Arabia from Saudi Cancer Registry data in 2012 found 14,336, majority are female. There was limited data regarding outcome of patients with hematological malignancies and cardiac arrest admitted to the intensive care unit at in Saudi Arabia. The aim of the study is to report the outcome of hematological malignancies patients admitted to the ICU after cardiac arrest. Objectives is to measure ICU hospital mortality and hospital length of stay, and determine the predictor of in-hospital mortality. Study design, it was retrospective observational study of adult patients admitted to the ICU. Study area and setting ICU of King Abdulaziz Medical City, Riyadh, Saudi Arabia from 1999 to 2017. Study subject inclusion criteria more than 18 years admitted in ICU with hematological malignancies admitted after cardiac arrest. Exclusion criteria, patients with non-hematological malignancy and non-cardiac arrest patients. Sample size and technique. All patients in the prospectively collected ICU database maintained by data collector, including all demographic variables such as age and gender, in addition to physiological parameters like Apache, GCS, bilirubin, creatinine, lactic acid, INR, and VF ratios. Statistical analysis comparison of baseline characteristic and the outcome between survival and non-survival category data were presented as a frequency and the percentage were compared using the chi-square or Fisher exact test. Continuous data were presented as median with the first and third quartiles and compared using the non-Whitney test. So the result is during the 18 years study period, 35 patients meet the criteria and were including in the study. Those patients had hematological malignancies admitted to ICU after cardiac arrest. 13 patients survived and 22 died. Majority gender was male, was 26 patients, and female was 9 patients. The median, the characteristic of the hematological malignancies patient admitted to the ICU after cardiac arrest among survival and non-survival found that the median age was 58-year-olds. Diabetes mellitus was the prevalent chronic disease in 10 patients, followed by chronic heart disease in 8 patients, chronic respiratory disease in 3 patients. So, according to a comparison baseline characteristic of hematological malignancies patient who is among survival and non-survival, found that patients who had lactic acid found to be higher in mortality. So the table 2 outcome of hematological malignancies patient admitted to the ICU after cardiac arrest among survival and non-survival, I found that ICU mortality was 14%, and ICU length of stay median both are 5. Both are 5.
Yeah, Modi, it's not 14%. 40%. 40 people. 14 people died.
Oh, sorry, yeah, 14 people died and 40%. Yeah, 40%. Yes, sorry.
Okay.
So our study has several limitations. First, that retrospective design may have.
Can you go back to the previous slide before? One before. So this one, I think, don't focus only on the p-values because that's no, the one next. There's a lot of important information here. Forget about the difference p-value. This is not that important. So these patients were 80% of them were on the ventilator. So 75% on pressor.
Yes.
They had Apache of 28, which is 28 is high or is low? It's very high. Okay. Heart rate, when they came, they are tachycardic, hypotensive. Correct?
Yes.
So don't look at only what's significant p-value and focus on it. It's distracting. There's a lot of information here that describe what type of patient you are dealing with. So when they came to ICU, these patients were very, very sick. Hypotensive, tachycardic, high Apache, low GCS. What? Lactic acid, you mentioned lactic acid. INR is a little high. PF ratio is generally low. Yeah. PO2 or filter ratio need to be fixed, not correct. You cannot have everybody 176 and the 2 groups 268. But this number is not correct. Okay.
Okay.
Next.
Should I comment on this or خلاص I will continue?
No, it's okay. Next.
So regarding our limitation, our study has several limitations. First, that the retrospective design may have induced selection bias and the substantial rate of missing data. Accurate data on recitation duration may be unavailable due to lack of witness, inability of bystander to record the time of event. Secondly, the relatively small sample size. Still the work in a process, so more data will be collected about the type of cardiac arrest and the type of hematological malignancies. Multivariate logistics like regression analysis will be carried out among patients with hematological malignancies admitted to ICU after cardiac arrest to identify. So in conclusion, analysis selected different independent variable, which was statistically and clinically not significant, except patients who had lactic acid found to have higher mortality rates. Okay, any questions?
Good questions. So I think the first question comes to my mind, why this question is important. Second question is what hematologic malignancy means. What's the definition of hematologic malignancy?
Hematological malignancies is
and when you do study, any term you use, you should have definitions. For hematologic malignancy here, what do you mean by hematologic malignancy? I don't know what you meant. So what's hematologic malignancy? You need to define it when you write the paper.
Yeah.
Totally, yeah, go ahead.
It's it's cancer that's been in a blood-forming tissues such as bone marrow or in the cell or in the immune system, like leukemia, lymphoma, and multiple myeloma.
So is this what you use? It has leukemia, lymphoma, and multiple myeloma? That's what I think. What this question is not general definition. I'm asking you what did you use in your study?
What is type of hematological malignancies we are studying?
Yeah.
You mean?
Yes. I think what you said is probably correct.
Lymphoma and leukemia. Yeah.
Lymphoma, leukemia, multiple myeloma. These ones. Yeah. Second question: why this study is important?
It will be helpful in the management of the patients if we are suspecting that it will be poor prognosis and costly effect also. So what is the target of our management and how it will be helping us and what expecting us from that patient? I mean, the outcome this will be.
Okay, so very important. So this is a good answer. So the answer is you are trying to understand the prognosis of hematologic malignancy. So this information may guide decision about goals of care, for example. Huh?
Yes.
Yeah. So prognosis looks. So what's your interpretation? The outcomes were poor or good?
Poor, yeah.
Very poor.
Poor outcome.
Very poor or nos?
It was like a 22, almost from 35%. So 14%. I'm not sure it will be high mortality rate.
40%. People who died in the ICU, 40%. I don't know how many people died in the hospital. So it is high mortality, but it's not like 100%. It's not like everybody died. There are people who survived. صح? Should I put anybody hematologic malignancy, make him no code? No. Based on this, no.
Yeah.
Yeah, there are people who die, but there are patients who also survive. Second question, how does your study compare with the literature? Are we doing better, worse? And then I'm gonna ask Dr. Hani to comment. Hani is that? So how does your study compare with the literature? You found the study from France, right?
Yes.
What's the mortality in the study in France?
The mortality was 22%, I think. Sorry, 24%. 24%, yes.
It's ICU mortality or hospital mortality?
It's ICU mortality.
So 22% here, 40%. Is there a reason why our numbers look worse?
I think it was multi-center study, like 7 medical ICUs, all of them ICUs. It's إحنا مقارنة يعني it's only one ICU. So
that will not
like,
explain. That will not explain it. So you need to look. I think this is what this is what research. You have to look at their study, find the characteristics of their patients. Are our patients sicker? Are they more ventilated when they come to us? Are they more on pressors? Is there more acute leukemia? I mean, acute leukemia would be the worst. What type of hematologic malignancy? So is it related to the type of disease or it's related to the care? That's important. Dr. Hani, تفضل.
السلام عليكم Prof. يعطيكم العافية. It's really interesting to examine this contrasted with the literature. I'm not sure how much is there data available. Is there other than that French study you found, Doctora, or only?
The similar to our study, it was the French study. There is like limitation, like they are not in hematological malignancies, like the general term of malignancies.
Okay. So that's a good news that you're looking at the prognostic factors, both the poor and the good prognostic factors. What I will suggest, if you don't have, as Prof mentioned, it's not only looking at those with a p-value significant, looking at other factors. If you are still in the analysis phase, what you can ask your biostatistician is to see those numbers that are trending, the factors which are trending towards a good prognosis, see if he can make a composite score for you. And those which are trending towards a poor prognosis, maybe he can do it and see like a composite score. That helps sometimes, although it's just an observational, retrospective, but you may have something additional to add to the literature. So, for example, the patients with the high lactate, with the needing vasopressors, and so on, so on. So this score, they really performed badly.
Yeah.
On the other side, those who had the early initiation of some therapy, they did better. So just a suggestion, since you are in the midway of your analysis. But I really like it, and good luck for all the team. Shukran, Prof.
Thank you, Dr. Hani. Great suggestion.
Thank you.
So I think the French, you need to look at the French study, and if it's included cancer in general, is different. Then that's different. I mean, solid tumors generally have better prognosis than hematologic malignancy. Leukemia will be really not good. Dr. Iman? Have a comment from Dr. Iman?
Hello, yes. Good evening.
Good evening.
Assalamu alaikum. Yes, I missed almost maybe most of the lecture. My question regarding this study, the cardiac arrest. I mean, what was the, cardiac arrest, they arrived in emergency, arrested, and how long it took for the ROSC. I mean, these are also will count on the outcome. So is this considered in this study?
Modi?
I think because the patient should be admitted in ICU. It is not, they have rocks, then, I mean, the patient is regain rocks, then they admitted. So if it's admitted ICU without dying in like ER, I think it will be included in our study.
No, I mean the ROSC itself. I mean the duration of ROSC, the cause for arrest was septic, not septic.
Yeah.
All these data.
This is unfortunately there is Yeah, it is not, unfortunately, we have some lack of data regarding this time of like CPR, how, when to take how much cycle, what's the type. We are in the middle of this analysis. So
yeah, I'm asking this because this is, then you cannot say independent, then something dependent on something. So I don't know how can we relate this for the outcome in ICU.
It's a very good point, the Freeman. I think so. This, so I think what Modi is trying to say. This data is from ICU database. Some of these details that you're asking for, which are really important, are not there, and that's what Dr. Modi mentioned. She's now going to review the charts for these patients.
Thank you.
She's going to collect the data on. So her plan to collect some additional data about the rhythm. You're absolutely right. The duration of the cardiac arrest until ROSC, and the type of hematologic malignancy, because we don't have this data in the database.
Yes.
So she's going to collect some, without going to extensive data collection, some critical items. You mentioned important ones of them. Duration of cardiac arrest. صح Dr. Modi? Any natural question when we see patient cardiac arrest. أول سؤال بنسأله how long was the cardiac arrest? Makes big difference. That's what Dr. Imam mentioning. Somebody arrested for 1 minute is different from 20 minutes.
Yeah, definitely.
Yeah.
So yeah, we'll look for it, inshallah.
Thank you.
Excellent
Good
point.
luck.
Thank you. Yeah, great. Thank you very much. Good job, Dr. Modi, and good luck. I think it's going to be a good study. Next presentation. We're really very happy today and excited of having nursing research and Ms. Wajdan Rassama. Please correct my spelling. Going to be presenting. She's one of Ms. Wajdan is one of our senior ICU nurses who are doing great job actually in many projects, and she did this project on, again, cardiac arrest in the hospital and the effect of the use of AED on survival of patients. So she's going to tell us about what she's done. Great work. She's also leading on another project for monitoring ICU, monitoring patients on the ward. So really very happy about the work she's doing. Wajdan? Wajdan, can you can unmute your microphone? Wajdan, can you unmute Wajdan, Rose?
Thank you, Dr. Yasin, so much.
I
I think because I got the internet interruption, I'm not anymore a host. I cannot share also my slide.
دقيقة المكي. Rose, can you make? I'm not able to make your host. I don't know how the others were able to share.
Come again, doctor?
Can you make Ms. Wajdan a host?
What's the name? Wait.
Wajdan. Wajdan, can you raise your hand so she can see?
Okay, I saw her.
Okay, good.
Okay, she's now a host doctor.
Okay,
Co-host,
excellent.
I mean, sorry.
Yes, thank you.
I'm trying to share my screen. I'm having difficulty.
If you want to send to me on WhatsApp, and I'll share it for you.
I sent it to you, Doctor.
You send it to me?
Yes.
Can you see the slide now?
أيوة دكتور. السلام عليكم. مساء الخير. My name is Wujdan Rassas. I'm a clinical resource nurse in respiratory ICU. I would like to start thanking Dr. Arabi for allowing me to join this webinar. And thank you for the all support that you've been giving to me since I joined the National Guard. So the research study is about automated external defibrillator association with risk among hospitalized patients with cardiac arrest. So the background using of the AED has been proposed as a strategy to reduce time to defibrillation to improve survival from cardiac arrest that occur in the hospital setting. The AED, I mean the AED function and the defibrillator, not the AED device itself. However, current evidence to support the use of AED in hospital has been mixed and limited to single center studies. Also, the studies there was a gap between the studies for in-hospital cardiac arrest. Latest one was in 2010, and the remaining study it was about out-hospital cardiac arrest with AED. Although these devices may be less effective or potentially harmful when used in hospital, where only about 1 to 5 hospitalized patients might have initial cardiac arrest rhythm with shockable rhythm. The aim of this study to recognize the effect of utilizing the AED function in the defibrillator device during cardiac arrest and the number of return of spontaneous circulation, which is ROSC, among hospitalized patients. So it was a retrospective observational cohort study. It was about 177 events. And the data was extracted from the Code Blue chart from Best Care at KMC. And the data included demographics such as age, gender, physiological parameters such as arrest time, AED use, ALS initial time, baseline status of the patient, and outcome data including hospital mortality. Interval variables summarized and reported in terms of mean and standard deviation. And categorical variable were summarized and reported in terms of frequency percentage. The data was compared among groups based on age, gender, AED was used or not, ROSC success or not, and CCRT was activated or not, or no. So as you can see that the majority of the patient was above 60, like 72.9% from the 177. And the male patient was about 101, which is about 57.1%. Female were about 76 patient, which is about 42.9. AED was used on 50 event, which is about 28.2. The ROSC rate out of 177 was 122, which is about 68.9%. Code cardiac arrest under when the patient was still under CCRT was about 47%. And people who met CCRT criteria but was not activated, 35% from the cardiac events. Here is the frequency of cardiac arrest events in patient hospitalized. We can see the the highest majority is under internal medicine, followed by nephrology patient, coming after that cardiac science together with the pulmo. And this table shows the mean and the duration from arrest time to initiate the BLS or to initiate the ACLS or code nurse to arrive to the event or the physician arrival. As we can see in the table that from arrest time to BLS initiation, the mean is 0.02, which is about 0.02 minutes. And from arrest time to initiate the ACLS, 2.20 seconds. And from arrest to code nurse arrival, 1.5 the mean, and the maximum was 5 minutes for her to arrive or him to arrive. And for the physician, it was 1.67, which is about maximum 7 minutes. The outliers was excluded from the calculation.
Wajdan cannot hear you. Can the others hear Wajdan? I cannot hear her.
سوري دكتور أنا إيش آخر شيء وصلت وأنتوا تسمعوني؟ I explained the table 3 ولا ما سمعتوا؟
أنا ما سمعت شيء.
طيب
هذا
أوكي.
table ما سمعته.
Okay. Table 3, it's display the participant characteristic according to whether ROSC was achieved or not. There were no differences by age or gender or AED used. P-value was not significant. There was only slight significance between the availability of ECG strip and ROSC rate. And patient who was under CCRT was significantly associated with the ROS rate. Other variable didn't significantly associated with ROS rate. Clear ولا need more explanation?
لا clear بس يعني يمكن we can emphasize the AED because this is really your objective صح؟
أيوة, the AED was not associated with ROS rate. It was used in only 28 patients. It was used only in 50%, and it's about like 28 patients from the 177.
So with Dan, but just try for me to understand, and maybe the other colleagues will be asking the same question. These are 177 cardiac arrests, صح?
Yes.
In the hospital wards. These are hospital wards.
General wards, yes.
Not
including
ICU,
critical care area, yes. Not ICU, not emergency. No.
Wala ER. Okay.
No.
Out of these 177, 54, which
AED
is about
was
1/3, was used.
Yes.
AED function.
Yes, AED function on the defibrillator mode.
يعني الممرضة حطت ال AED أنا أصلا machine
حطت الديفيبريتر وبعدين شغلت ال AED function.
شغلت AED with the idea is to try to identify what's the rhythm, and if it's shockable, it will shock.
Yes.
That's the idea.
That's the idea.
باقي ال 122 just use the standard.
The standard. Until the doctor will come and the doctor will carry out. He will give the shock if he's there and the epinephrine dose.
طيب okay.
هنا كان في significant every time that they will use the AED mode, it was associated with the longer time to initiate the ACLS. So there will be a delay in the ACLS initiative if they use the AED mode. It was like when the AED mode was used, 2.9 the mean, and was not used 2.1. So it's about the different like 0.8. So I'm not sure. Is it because they are waiting for the AED to shock or not to shock? That's why the ACLS was delayed, or also it's related to the doctor. If he's not there, they will not give the epinephrine. What's the reason for delaying the ACLS is really not mentioned in the code blue recorder.
Yeah. I have another explanation, maybe. But do you wanna carry on until you finish, or you wanna discuss?
لا عادي دكتور, you can. يعني I remain only, I think, one table, fine.
I see hand raised. Dr. Sarah, you raise your hand. My question is, Sarah, Dr. Sarah, تفضلي. Unmute. Can you unmute Dr. Sarah? Not even. Yeah.
Dr. Arabi. The question is this 2.9 and 2.1, this is like minutes?
Yeah.
وجدان؟
أيوة, minutes.
يعني we're talking about 2.1 minutes versus 2.9 minutes.
أيوة. Yes.
So it's like, it might be, I don't know if you agree, it might be statistically significant, but is it actually clinically significant difference? We're talking about 0.8 part of the minute. And is it because like they need to like press an extra button, or like how do we actually activate this function?
Activating this function is easy by pressing only analyze, but deactivating this function when the physician arriving, it's take like it's also easy, but
بالظبط.
سوري ما أعرف وش هذا الصوت بس عطيته ميوت. I'm sorry.
Me too. Yeah, I think
deactivating ياخذ شوية buttons وأحيانا النيرسز يعني under pressure they get confused لين يسووا له deactivate when the doctor arrives.
so. I think you're raising very important point. First, this difference is small,
Yeah,
so maybe not clinically important.
and it's still included within the initial 3 minutes. It still didn't exceed 3 minutes.
صح. الشيء الثاني, the reason for this could be the operation of the AED, that you have to push the button and then wait until it analyzes rhythm, and so maybe that part of it. But there's another explanation that comes to mind. طبعا using AEDs you try to expedite things, but here it looks like it's the other way around. I just, I was thinking about this before. In the ICU, would you use AED if somebody arrests?
According to our policy and guidelines, we should use.
But do we use it?
Actually, because of the doctor is around most of the time, we don't use it very frequent in ICU because the doctor is available most of the time and he will ask to give the shock or give epinephrine when he is around.
كويس. And the nurses are more expert. They
they
can
know the
recognize the
rhythm.
rhythm.
Yes.
Okay. So what
If I
I'm
may,
trying to say here, it is possible that AED was used in wards or in settings where people don't have enough expertise, so they use AED, and that's why things. So that they use AED, and that also led to a delay in ACLS. Just they are not familiar with cardiac arrest.
One more thing, doctor, and the patient the floor is not connected to the monitor in 24 hours. So the initial rhythm is not really recognized for the nurses or for the staff physician.
Yeah. Very good. Okay, so let's go to next slide.
This table, it shows that the AED use was less in female, but it's not like significantly different because the p-value is only 0.065.
Okay. Can you have explanation for this?
I'm not really sure why female is receiving less AED mode. I'm not really sure.
I don't think there's any particular reason except that certain wards were using more AED and others, and these wards have more males or females. I think that's it. I don't think it's a male-female issue.
I don't think so.
Yeah.
Especially in hospital setting. Maybe if it's out hospital, they are less receiving the AED mode.
Correct. Okay.
Table 6, it's the predictor of risk rate. It's actually same what I mentioned in the table 3. Only here what's different, the odd ratio. For the people who's under CCRT, they have 5.87, which is more protective value than others.
Nice.
That's
so among
the only difference, yeah.
And the use of AED, what did it do? Did it help or no?
Not really associated with risk.
Yeah. We have some hands raised. Dr. Sarah, again, your hand raised.
Just a comment about maybe we don't see a difference in here, given the nature of the cardiac arrest, which was predominantly in the internal medicine floor. I don't know, from our experience, we have noticed that those are usually PA arrests, related to respiratory issues where like the shock is not indicated. I wonder if this AAD comparison happens in more of the cardiac floor where the primary source of arrest would be arrhythmias. You might see a difference when AAD is utilized by an inexperienced, or like as Wujdan mentioned, in an area where the detection of the rhythm is delayed till the actual monitors are attached.
Excellent point.
That's actually one of the limitation. I will mention it in the discussion, Dr. Sarah, that using the AED is more effective with patient who's having shockable rhythm, which is very rare happening in, which is about 1 to 5 patients per hospitalized patient. And sometimes in the floor, when the nurse or the healthcare provider will go inside the room, the patient might already have the shockable rhythm. ما أدري إيش قاعد يصير.
Okay.
When the nurse already attended the code blue, the patient might already done from the shockable rhythm and already he is to the assistole and the BEA.
Yeah. So I think the question here, how many of these 177 were shockable? Do we have this information?
No, it's I cannot reach it if they didn't use the AED mode. That's one of the limitation. If the initial rhythm they didn't use the AED mode, I don't know if it's shockable or not.
But in general, even I mean, even the defibrillator, you'll have a rhythm. Is it PA or VFib VTAC? How many VFib VTACs?
It's not mentioning in the. It's not a lot. It's not mentioning in the code blue records. This is one of my limitation as well.
Okay. Fine. Next.
We found that utilizing the AED during cardiac arrest in patient was not associated with the risk, while randomized control trial are needed to confirm these findings. The current use of AEDs in hospitalized patients might warrant reconsideration.
I think the point raised by Dr. Sarah is important. Does this depend on the incidence of shockable rhythm?
Yes, exactly.
In medical floors, it's mainly PEAs.
BA and assistole, yeah.
Assistole. This probably doesn't matter that much. And it would be probably matters more to start ACLS right away and give epinephrine, stuff like this.
Yeah. That's
but if
my
it's cardiac,
what
cardiac
I'm
ward,
yeah.
cardiac ward, it may matter big time.
Yeah.
I think you need to try to find the rhythms, which then I think would be very important for the paper.
Inshallah, I will try to maybe have some connection with the Code Blue team to ask to give any education while they are documenting the floor nurses to mention this in the report.
Okay, very good. Any other questions? People can raise hand or put in chat box if they want.
One more slide, Doctor, I think.
Yeah, okay, this one.
So the limitation was for my study, that's the small sample size, because I excluded the critical care areas due to they are not using the AED mode. And the time of arrival of an AED to patient bedside in the literature review was shorter than the one in our records. AED was not used in a large number of patients in our sample during cardiac arrest. And you can go next, Victor, recommendation. Recommended that more studies should be more conducted with a larger sample size, having subgroups of shockable rhythm, and most of the sample should have AED used and then during cardiac arrest by a trained professional.
Okay. Excellent project. Very nice. Any comments or suggestions? Great work, Wujdan and Lena and Modi. We had really great presentations today. So we encourage you to keep going with these projects and utilize the suggestions you heard today to strengthen them and move this towards full publication. Great work. Thank you, everyone, and have a good night. Assalamu alaikum.